네, 안녕하세요. 서울 뿌리 깊은 치과의 조영진 원장입니다.
Greetings, I'm Dr. Jo Young-jin of Seoul Deep Rooted Dental Clinic. Today I'm going to talk about impression taking to fabricate accurate implant prosthesis. In order to come up with prosthesis, we need to take impression. In the past, we would use analog ways. Now we use digital dentistry and do scanning. However, accurate impression taking is still very important in making prosthesis. Today I'm going to talk about this topic. First is about understanding implant impression. Second, classification of implant impression. Third, abutment level impression. Fourth, fixture level impression. Fifth, precautions for each situations. And sixth, the summary. First is about understanding implant impression. This is a process of producing a replica of the patient's oral cavity. Implant is placed here. By taking impression, stone model is made. We reproduce the patient's oral cavity. Three-dimensional duplication of fixture position. This can be done using transfer jig or impression coping. Impression coping is the analog ways to do it. Recently, scanner and digital dentistry is used. Scan body is used to come up with virtual model. Clinically, it is similar process. Today, I'm going to talk about the analog ways, the impression coping, and impression taking. The impression coping and scan bodies, they are used in an intermixed manner clinically. You do not need to fixate whether it is analog or a digital way. You need to choose the right option depending on the situation. If you're going to use impression coping, as shown in the images, pickup or transfer type impression coping can be used to reproduce the oral condition. Scan body can be used also, and scanner can be used to make a virtual model as well. These are all impression taking process. This is the process that we use frequently, clinically speaking. Transfer type impression coping is placed on the implant body. Impression is taken and a stone model is made. Master cast is made. Custom abutment is made. After connecting custom abutment, this can be scanned or impression can be taken again to make final prosthesis. This is an intermix of analog and digital dentistry. This is very frequently used clinically speaking. Now I'm going to talk about the classification of impression taking. First, this can be divided into abutment level and implant level. Depending on the tool that is used, this can also be divided into pickup or transfer type. Depending on whether impression is taken directly or indirectly, it can be divided as well. Depending on which level impression is taken, classification can be divided into two categories depending on whether you take abutment level impression or implant body level impression. Depending on the type of coping that you use, whether you use pickup type or transfer type. As for pickup type, it is picked up with tray, and for transfer type, this is also used for impression later. This is not all, but let's take a summarized view. Abutment level It is connected within oral cavity and impression is taken in the same way as natural teeth. That's the direct method. One piece or two piece abutment may be connected. Impression cap or coping can be used for indirect method. In implant level, you cannot directly take impression of the implant, therefore transfer jig needs to be used. Depending on pickup type or transfer type coping, it can be divided as well. First, let me talk about abutment level impression. As mentioned earlier, abutment is connected and this is prepped or not prepped like a natural tooth and impression is taken. This is direct impression taking method. If you use impression cap or impression coping and proceed with indirect impression, this can be a choice as well. In the case of a direct impression, abutment is connected. You can go with or without prep. You use the same way as the natural tooth impression taking. Stone model is formed. The abutment is replicated on the stone model. Impression is taken the same way as when taking natural tooth. It is very simple. There's no need for tools. Because it is made into a stone model, there can be margin bubble. There can be damages to the margin during die trimming. This is the downside. If you connect one-piece type abutment and because of the space with the antagonist or the path with adjacent teeth, if you prep, you can only make a stone model using direct impression taking method. If you connected a stock abutment and modified it, you need to take abutment level direct impression. Direct impression is used when custom abutment is connected and if it has equigingival or supragingival margin, without using cord, you can take a direct impression to reproduce margin and have accurate stone model. Direct impression can be very useful in these cases. As for indirect impression, abutment is connected. Impression is not taken thereafter. Impression cap or impression coping is used to form a abutment analog or abutment replica of the connected abutment. There's no side effect related to die such as margin bubble or die fracture. The analog, if it is not damaged, then it can be predictably reproduced in an accurate manner. However, if abutment has been modified or milled, this method cannot be used. Therefore, there is limitation in terms of indications. Among abutment level impression, if you use impression cap or transfer type coping to do impression taking, or you can also use pickup type coping impression. This is three-piece abutment connected to US implanted body. This is abutment for screw type prosthesis. Three-piece or four-piece abutment is connected, and on top of it, the pickup type coping is connected to make a stone model to fabricate screw type abutment implanted prosthesis. On the right, two-piece abutment is connected. One-piece or two-piece abutment is connected to the implant. Impression cap or transfer type impression coping is used to take impression. Final prosthesis would be either cementation type or ER combination type. As shown in the image, on the implant body, one-piece abutment are connected, and depending on the height of one-piece abutment, the height of impression cap differs and they are color coordinated. If you use the same impression cap as the abutment height and take impression, the impression cap will be picked up and abutment will be reproduced. When you connect the abutment analog, a OSSTEM model is made. Cement-type prosthesis has been fabricated and placed. If there is no modification on abutment, be it one-piece or two-piece, we can take this kind of impression-taking method. However, there is limitation in terms of indication. Next is fixture. Next is implant level impression. This is a most frequently used method. Implant is placed within the oral cavity. Pickup or transfer type coping is used to reproduce the three-dimensional position of the implant on the model. You can use pickup type coping or transfer type coping. Bite impression coping has been introduced so that you can do bite registration and impression taking at the same time. This is a type of transfer type coping. As for pickup type coping, the impression coping is removed along with the impression body. As for transfer type coping, the impression material is removed and the transfer coping, which is within the oral cavity, is removed, and then it is transferred again to the impression material. Pickup type impression. There's no change in the coping position. It is not transferred. Once the impression material solidifies, it comes with the impression material, therefore you can get a more accurate impression. You need to remove the pickup type coping after unscrewing it. Therefore, open type tray, where a hole is punctured on the plastic tray or custom tray, needs to be fabricated. After removing guide pin, the impression body needs to be removed. Because it requires unscrewing, in the case of most posterior teeth, if the patient has limited mouth opening, there can be some difficulties. There needs to be screwdriver on top of coping. Therefore, in the case of patients with limited mouth opening, there can be restriction. In the case of multiple case, if the implants are placed in a parallel manner, it's okay. However, if there is angle deviation, once the impression material sets, the pickup type may not be easily removed. Therefore, you need to consider whether the angle is acceptable. You need to be aware of this before choosing the impression type. In multiple cases, if implants are placed parallel, it may be okay because the pickup and implanted body comes out at the same time. But if there's angular deviation, in the case of internal type, the connection is deep within the implanted body. If you have used hex type coping, then it cannot be easily removed. If the implant angle is severely deviated, you need to pay more attention in using pickup type coping. In TS, SS, and US, I wanted to understand up to what angle it is permissible to easily remove the impression material. In the case of TS type, TS hex type, it is 11 degrees, SS octet type 8 degrees, US hex type up to 20 degrees. Separation is possible. If it is non-hex, non-octet type, the range increases. In TS, it is 22 degrees, SS 40 degrees, and US non-hex, it is 40 degrees. Therefore, separation can be done easily. You need to be aware of these numbers. Let me share you a clinical case using pickup type impression coping. 3 implants were placed each, SS type for the posterior upper and US type for the lower. Impression was taken in the posterior area. Pickup type coping was used. It was connected to primary cast. The pattern resin block was made 24 hours before taking actual impression. It was cut thinly, and on top of it, open custom tray was formed. Silicone material was used. Pickup type impression coping was utilized. This was used to make a screw type prosthesis. Master model was formed. Wax up was done. Screw type prosthesis was fabricated for both upper and lower. Pickup type coping was used. Pattern resin block was formed. The reason why I make a pattern resin block is because if there's too much pattern resin in between coping because of polymerization shrinkage, the intercoping relation can be deformed three-dimensionally. The polymerization shrinkage continues to occur 24 hours. Therefore, 24 hours ahead of it, you need to make the pattern resin block. 80% of shrinkage occurs within oral cavity. You connect the coping with a pattern resin block. Pour the resin in the gap, and if splinting is done after 4 minutes, you need to take impression because it takes about 4 minutes for the impression material to set. So in total, it'll be about 8 to 9 minutes. Most of polymerization shrinkage would have occurred before the impression body is removed from the oral cavity. It is recommended to take impression 4 minutes after rejoining. After removing the impression material, the polymerization shrinkage continues, although minimum. Therefore, stone pouring should be done as soon as possible. If you do not do splinting using pattern resin, the coping is set using just a polyvinyl siloxane. Therefore, you don't need to pour stone immediately. The accuracy of impression. There's controversy over which is more accurate, splinted or solitary. You may think that doing splinting would be more accurate. Some say the difference is not statistically meaningful. Others say that it is better to use the solitary type. Depending on how parallel the implants are and the amount of impression material used, the way to form resin block, I think there can be differences. With the development of material, it is difficult to say which is better. It just depends on what you prefer. Next, I'm going to talk about transfer type impression. Unlike pickup type, as for transfer type, you put in the impression coping within oral cavity, take impression, and remove it and transfer the impression body. Stock tray can be used, which is what we use very commonly. In multiple cases, it does not come off with the impression body. It is removed with elasticity of impression body. Therefore, even if there's a bit of angular deviation in multiple cases, there are less restriction. However, because the coping is transferred and connected and the impression body is deformed due to elasticity, there can be more error. It's the same with impression material. However, if the angle of the implant body is three-dimensionally deviated rather than using pickup type, it may be more favorable to use transfer type coping. The possibility of impression material not being removed will be reduced. Let's compare transfer type and pickup type. Compared with pickup type coping, it is designed so that impression material needs to come off easily, therefore it is less geometric. the blue portion in pickup coping, you can get a very good sense of grip. You can get a good sense even if you don't take x-ray. Transfer type, there has been a lot of improvements, but compared with pickup type coping, the sense of grip falls. Therefore, there can be position error. After taking impression, you connect the analog and then reposition the impression body. You cannot do it everything by yourself. When this is repositioned by your staff or by the lab, at times there can be positioning errors. As it is being transferred, there can be errors. As for transfer type coping, repositioning is done based on the area that is exposed above the gingiva. If this area is too short, the stability may fall. There can be vibration when you do stone pouring and other movements. The possibility of positional error exists if the gingiva is thin, and if there is sufficient length that is registered, it's okay. But if the implant is placed very deep, or if bite impression coping is exposed only a little, and if there's a bit of geometric form, there can be positional limitations. Let me share with you a clinical case. The patient came to my dental clinic after having had oral surgery due to intraoral lesion in the upper right number 5, 6, and 7. After surgery, bone defect was formed and there was a lot of scar on the soft tissue, and the condition was not very good. It was very thick. Vertical GPR was very difficult to do because of limited mouth opening. And although there is a lot of difference in platform height between number 5, 6, and 7, I wanted to distance number 5 and 6 because of platform difference, and using abutment in the middle, I plan to form a prosthesis. In number 6 and 7, external type aesthetic abutment was used. This is a 3-piece abutment. The color height is about 3 to 4 millimeter. Healing cap was connected. In number 5, implant was placed and healing abutment was connected. In number 5, implant level impression was taken. Number 6 and 7, abutment level impression was taken. Screw type prosthesis needed to be formed. Therefore, pickup type abutment level coping was used to take impression. Abutment analog was utilized to make a master model. In number 5, a fixed analog is in, and in number 6 and 7, abutment analog are in. Screw type prosthesis was fabricated and delivered. There was stark vertical difference in terms of platform, but using the distal abutment, the platform was adjusted, and in red, this is abutment level, and mesial to that, it is implant level. This was how I provided screw-retained prosthesis. This was at the time of delivery. This is at recall last year. Over 10 years, the patient has maintained it well on X-ray. You can see very favorable conditions. I would like to now talk about precautions for clinical situations where we use abutment level, implant level, transfer coping, and pickup coping. Regardless of whether it is pickup coping or transfer type coping, there can be cases where coping are in contact with one another. We need to make sure if the distance between implant is too close or if the angle is deviated. We need to make sure that the two copings are not in contact visually, and if you cannot really see it, you need to use the floss and check whether there's no resistance. If there's resistance, even if it means adjusting coping, you need to make sure that there's a space between coping. And then proceed with impression taking. Not just contact between impression coping, Within oral cavity, impression coping may be apart, but when we connect the analog on the impression body, at times the implant analog could be in contact. This is something that lab technicians should be doing, but you need to make the order clearly so that the implant analogs are not in contact. You need to make sure that there's no positional deviation due to the contact. When you connect the impression coping, if you suspect something went awry, you need to take PA X-ray in a parallel manner to make sure that it is connected securely. And proceed with the following steps. In the case of internal type, unlike the external type implant coping, it is difficult to make sure whether it is fully in or not. In the case of OSSTEM, there's a notch on the implant platform. So if you look at the notch position on the X-ray image, you can make sure whether it is fully in. In the case of external type, if it did not go fully in, you can see it clearly on the X-ray image. You can connect it. Once again, you need to check that this is done correctly before moving on to the next clinical step. When you take an impression, if there is gingival recession or mobility in the teeth, or there could be large embrasure space, in order to protect teeth and to remove impression material easily, you need to do block out even if it is cumbersome. If this is not visible, rather than taking implant level impression, you need to use a scan body and do digital impression scanning. When you connect the abutment and take direct impression after that, more so than not, in subgingival margin, there's residual impression material, and this could cause inflammation. Especially in the case of abutment level direct impression, after taking impression, you need to check whether there's residual impression material. This may be minimal, but you need to inform this of the lab technician or the staff in charge. In the case of pickup type coping, when you connect it to analog, you need to hold the analog instead of the impression body. This is to prevent the impression coping rotating on the impression body and becoming deformed. This may sound trivial, but this is quite important. In the case of transfer type coping, positional error can occur very frequently. You need to train your staff and lab technician that it needs to go fully in. A lot of people use bite impression coping these days. The superior portion of bite impression coping look the same, although you may have used a different bite impression coping for number 6 and 7. They can be used interchangeably. For example, I have used A in number 6 and B on number 7, but at times I may get confused and put B in 6 and A in 7. They can be interchangeably used, therefore you need to make sure that accurate coping and analog goes in correct positions. When making soft tissue replica, if the thickness is not appropriate, implant platform can be submerged within the stone. This is another precaution we should take when making model after taking impression. There's another point you need to bear in mind in transfer type coping. When you don't block out the screw hole after taking impression, such impression material can stick out, and this can be a cause of repositioning error. You need to block out first, or if you have not done that, you can use tools like a sharp tissue forceps to remove it so that it does not interfere when transfer coping is repositioned. In summary, to make accurate implanted prosthesis, there are different types of ways to take impression: abutment level, implant level, direct impression, indirect impression, pickup type, and transfer type coping impression. There's no one-size-fits-all method for all cases. Depending on the type of abutment that is used and the impression method that I choose, you need to make relevant choices before proceeding with prosthodontic phases. In this lecture, I've talked about the impression taking process to make accurate implant or prosthesis. Regardless of whether it is implant level or abutment level, you need to choose the accurate impression taking method to come up with accurate prosthesis. I hope today's lecture was of help. If you have any questions, please leave your questions on dental website. This is the end of my lecture. Thank you for watching.